30 odd years. So you know it was rare, but these days it's coming up more often. You ask if I'm qualified to present this topic, right, Sister Herbert? Well, I've been a radio technologist for over 30 years, from we were using grandfather equipment. These are modern equipment we have now, but they were grandfather. I ran a mammal lab at New York Medical College floor and Fifth Avenue Hospital for over 2 years. When the medical college moved to Valhalla, the hospital changed from an acute care facility to caring for the grossly retarded. So I didn't have to work there anymore. But I went down to Cabrini Medical Center in Lower Manhattan. And I want to admit that I'm not a clinician. But I have worked closely with surgeons. I was trained to read the mammo films and give preliminary readings. When I was trained on a more modern equipment, I had to go to other hospitals like Beth Israel Hospital to train the X-ray techs how to use the machines, the new machine, because the company would come and they would train me, and then I had to train others. And this is how I met Brother Thorpe at Joint Diseases when I went over there. We hope you will leave with information you can share. The Bible says in 3 John 2, and the elder just prayed it, "Beloved, I wish above all things that you may prosper and be in health, even as your soul prospers." John was concerned for Gaius' physical and spiritual well-being when he wrote that. This was in direct contrast to the population heresy of the day, and that taught the separation of spirit and matter, and despised the physical side of life. But we cannot despise the physical side of life. Why do you think we cannot despise it? Today, many people still fall into the way of thinking. But this non-Christian attitude logically leads to one or two responses: neglect of body and physical health, or indulgence of the body's sinful desires. God is concerned for body and soul. As responsible Christians, we should neither neglect nor indulge ourselves, but care for our physical needs and discipline our bodies so that we are at our best for God's service. So essentially, what we're keeping healthy for? To be able to serve God. And today, I hope you'll be able to learn something. Where's Brother Troy? Brother Troy, I don't want to mess things up. Would you please come? Okay. General information. What is cancer? Cancer is really a number of diseases caused by the abnormal growth of cells. Normally, the cells that make up the body divide and reproduce in an orderly manner so that we can grow, replace worn out tissues, and repair any injuries. Sometimes, however, cells get out of control. They divide too much and form masses known as tumors. Some tumors may interfere with the body's function and require surgical removal, but they do not spread to other parts of the body. These are known as benign tumors. Malignant or cancerous tumors not only invade or destroy normal tissues, but by a process known as metastasis, cells break away from the original tumor and migrate to other parts of the body. There, they may form more malignant tumors. Anatomy of the breast. Just a brief thing, because I didn't want to make it too long and boring. The human mammary glands are paired subcutaneous organs on the anterior thorax, lying completely within the superficial pectoral fascia. The pectoral, you ever heard what man said, building up the pecs? Yeah, that's it. That's the pectoral muscle over there. Look at this breast now. You have to get used to this breast because later when we mention anything, you see the nipple? The nipple? Okay. And they have the mammary fats right there. You see that? You have the ampulla. Oh my goodness. Brother Troy, I'm in trouble. Thank you very much. My assistant, stay right there. And I want you to pay attention to the subcutaneous fat right down the bottom. Something else is coming up. Why? Yeah, right here. You see that? Those bubbles there? That's the subcutaneous fats. And then we're going to talk about lobes. So you see the lobe, this lobe here? This whole section is a lobe. See it? That whole section is a lobe. And the lobe has lobules. These are the little ones, are the lobules within the lobes. I don't think you need to know about the Cooper's ligament, but there's a Cooper's ligament. And then you have the alveoli. You should be familiar with that. With parenchyma removed. They've removed the parenchyma, the outer part of it. You can see that's what it means. And you have the laciferous ducts. And you have the ampulla laciferous sinus. But pay attention to the mammary fat and the lobes, because you're going to see, and this is the lateral view. So pay attention to that. Same thing, but in a different view. Anatomy and physiology. The breast is an endocrine target organ. What do you mean by that? The endocrine system is a collection of glands that produce hormones. What hormone do you think we're talking about? Huh? Estrogen and what? What organ? Hormones? That's right. Those two we're talking about. And changing hormone levels during a woman's lifetime affects alteration of its physical as well as microscopic characteristics. At puberty, the breast begins to grow under the combined influence of the hypothalamus. Where's the hypothalamus? In the brain. The anterior pituitary, in the head again, and the ovaries. Also, these are the primary endocrine sources responsible for breast growth. Complete development also requires normal levels of insulin and thyroid secretion. Did you know that? Development also requires normal levels of insulin and thyroid secretion. In early puberty and adolescence, estrogen is a primary hormonal influence on the developing breast. Since for the first year or two, menstruation, ovulation does not occur, and progesterone is not present in significant amounts. We always relate estrogen to females and progesterone to male, you know? But we have both. Estrogen stimulates growth of the breast by causing elongation of the ducts. Remember we just looked at the ducts? And proliferation of the cell lining and the major and terminal ducts. Remember the word ducts, it's coming back again. I'm going back? Okay. The resulting tissue sprouts. Remember what we're talking about, the growing breast? The resulting tissue sprouts are present for future development of breast lobules. Estrogen not only affects duct growth, but also stimulates the vascularity of the connective tissue, increases the volume and elasticity of the connective tissue, and induces fat deposition in the breast. Remember about fat deposition in the breast. We're going to come back to that later. The complete development of the adult breast, however, including maturation of the alveolar structure and the attainment of a final size and shape, awaits the added effects, estrogen and progesterone together after ovulation begins. Am I going back? During each menstrual cycle, the breast changes in size and nodularity. During each menstrual cycle, the breast changes in size and nodularity. 3 to 4 days before menstruation, listen to this now, 3 to 4 days before menstruation, increasing levels of estrogen and progesterone increases vascularity and ductal and alveolar growth in the breast and cause water retention. If you go to a doctor and he's going to do a mammogram and he didn't ask you when you're the last menstrual period, something is wrong. That's why sometimes when they come with these buses and you go and you just do it because the bus is there, it's not right. It's supposed to be done at special time, 3 to 4 days before menstruation. Because if water is retained in the breast, can you get a good picture? Ductal epithelial cells proliferate and ducts themselves dilate. Listen to the difference now. Ducts epithelial cells proliferate and ducts themselves dilate, and the alveolar cells enlarge and become secretory, depositing lipid droplets within the cytoplasm. That's why you have to be careful that the doctor asks you when was your last menstrual cycle? He has to ask you that so he knows. After menstruation, this cellular proliferation regresses. Water is lost and lobules and alveoli decrease in size. You see the importance of that? The degree of cyclic proliferation and evolution is not uniform through all areas of the breast. Neither does the breast return to its basal state. In response to repeated hormonal stimulation over the years of active menstruation, all breasts develop small areas that are to some degree nodular. So no matter what happens, everybody's going to have nodular breast. What we should understand, one should be cognizant of these physiological changes when examining the breast. I remember we're dealing with early detection. If you don't know the breast, you can't know what you're looking for, can you? So, because the breast is most active immediately before and throughout menstruation, remember what I said about activity? It's going to bring water, liquid in the breast. Many of the areas of nodularity that may be felt at the time can completely disappear 5 to 7 days after cessation of menses. That is why it's so important. The timing of the mammogram is significant. Furthermore, patients should be re-examined during the time of minimal change to adequately assess masses detected for the first time during the previous cycle. Everybody understand what I'm saying? So look what happened during pregnancy. And I want to pay special attention to what happens during pregnancy, because we're going to have some stories that we're going to tell you about. Because sometimes, because they always say you have to be 45, the younger people are not paying attention to the breasts. And they always say women, so the men are not paying attention to their breasts. But during pregnancy, the physiological change in the breast are extreme of those during menstruation. Preparation of alveoli cells for milk synthesis and secretion continues throughout pregnancy, so that milk will be produced at parturition. In addition to estrogen and progesterone, placental lactogen, prolactin, and chorionic gonadotropin are required to complete gestational development of the breast. Remember those words. I don't know if you're going to benefit from knowing it, but with the loss of estrogen and progesterone at the time of delivery, the effects of prolactin predominate, and alveolar cells actively synthesize and secrete milk. That's all that is happening when the woman is pregnant. And we're going to show you the breast of a pregnant mother who came down with something when we're doing the palpation. And we hope everybody will be able to participate. We're hoping that the males would come so we show them how to examine their breasts, but they didn't come. At menopause, he said he did. The men didn't come, but he did. Thank you, son. At menopause, with loss of ovarian activity, involution of the breast occur because of progressive loss of glandular tissue. The lobular alveolar structure disappears, and the breast consists largely of fat, some connective tissue, and mammary ducts. What we call that breast sometimes? What do we call that? Huh? No. Never hear some people tell you that the breast is hard. Why? Lumpy. What? Lumpy. What? And dense. What they call it? Tell it louder, Sister Herbert. Fibrocystic breasts. Thank you very much. Somebody's following me. Early detection, breast self-examination, or BSE, saves lives. So I told you what, in general, what was cancer. Now I'm going to be specific. What is breast cancer? Breast cancer is any type of malignant growth arising in the tissue of the breast, any type. Certain cells undergo an abnormal change and begin to process of uncontrollable growth. And that is what causes the cancer to grow, get out of control. These cells can invade neighboring tissue and spread through the body and establish new growths at distant sites. So breast cancer can take many forms and follow different paths. Not yet. I have to develop this part a little bit. These cells can invade neighboring tissues and spread. And that is why we want to do early detection. Because if you don't detect it early and it starts to spread, there's nothing they can do about it for you. Nothing. Can't get rid of it anymore. You're going to have it. Thank you very much. Tumors developed from one type of breast tissue do not necessarily look or act like those from another type of breast cancer tissue. What is that telling you? There are different types of breast cancer. All breast cancers are not equal. Some breast cancers grow rapidly, others evolve over many years. Some, perhaps microscopic at the time they are discovered, might never pose a threat to health. You have to kind of leave it at the same one. Breast cancer is almost always, why do I say almost always a disease of women? About 1% of all breast cancers occur in men and growing. That number is growing, I tell you that. Growing. And typically a disease of older women. More than 85% of cases occur in women over age 45. But when breast cancer does not strike younger women, it tends to be more aggressive. Why do you think it's more aggressive in young women? The cell growth. Remember, they repeat, their cells are growing more than others. I was going to give a case history, but I'll bring them later. Risk factors, major risk factors. A few risk factors are considered major, but some are not so major. So these include gender, age, and personal history of breast disease, a family history of breast disease, and a woman reproductive history. So the doctor is going to ask you all those questions when you go to him. Because they are more strongly associated with the development of breast cancer, they can alert a woman and her physician to the need for careful follow-up. Gender, about 99% of all breast cancers occur in women. I just said the 1% for men is growing, so maybe it's about 98% now. Age, breast cancer, like many cancers, is predominantly a disease of aging. That's why they start at 45 when they're going to give you mammograms. The older a woman becomes, the more likely she is to develop breast cancer. And it's always sad when these older women come, and especially they were always healthy. Family history of breast cancer. Look at this now. Women who have close relatives with breast cancer appear more likely to develop the disease than women in the general population. A number of studies have documented that women whose mothers or sisters have had breast cancer have a 2 to 3 times the usual risk of developing breast cancer. My sister died at age 56 from breast cancer. And her daughter died at 45 from breast cancer. So you see how important this is to do. And when she came, when I went to my sisters in Canada to help her, she was smoking so much and I complained about the smoke and she was mad. But she wouldn't stop smoking. And she was smoking from that little kid was small in that house. So you see, we have to be careful how we live because it can affect our children, eh? Recent analysis also indicate that increased risk is stronger by far for women whose relatives develop cancer premenopausally and or when the cancers were bilateral. If she has a cancer in both breasts, you're in big trouble. Skip one. Oh my goodness. Go back to where I was, please. Give me this. Thank you. Hormonal factors. A cluster of risk factors reflect one aspect or another of a woman's menstrual pattern of her childbearing history. Age at menarche. What is that? Age at menarche. When you start your period. The younger a girl at menarche, the greater the chances that she will someday develop breast cancer. Women who were 14 years or older at the time of their first menstrual period have 20% less chance of developing breast cancer than women who were younger than 12. And sometimes we hear that these young girls are starting earlier because of what they eat. You ever hear that? Age at menopause. The later a woman experiences menopause, the more likely she is to develop breast cancer. Women who are over age 55 at the time of last menstrual period have twice the risk of women under age 50. So early menopause, through surgical removal of the ovaries before age 45, exerts a protective effect. You see, sometimes we want to hold on to the ovaries, but if it's gone, we're better off. I really appreciate you. Parity. In general, women who have born a child have less risk of developing breast cancer than women who remain childless. The risk of breast cancer is known to be high among Catholic nuns. Why? I don't have any children. You sure I'm here? You sure? So we're going to go on to diet now. I think something got mixed up here. Something got mixed up. I think we skipped something in the middle. What do we just keep going anyway? Both epidemiologic and experimental findings point to diet as a possible factor in development of breast cancer. Bring my big chart. I brought this to remind us what we should be. I brought this to remind us about the 8 laws of health. Hormonal and hereditary elements are involved. The metabolism of foodstuff affects the production and secretion of hormones, So if you're not eating the right food, you're not going to be secreting the right hormones, which are in turn regulated by enzymes under genetic control. Risk factors. Something got mixed up here. Women who give birth before age 18, you hear we always telling the kids, don't go out and get pregnant. Huh? Well, women who give birth before age 18 have only 1/4 the risk of developing breast cancer of women who do not have a child until they're near 30. But we tell the children, don't go out and get pregnant so young, and we don't get married so young, you see? Such women have a greater risk than women who have never given birth at all. Nursing. Contrary to earlier beliefs, lactation does not seem to decrease the risk of breast cancer. What had appeared to be a protective effect from nursing now seems to have been a reflection of parity. You see that? You made a change? You understand that? The disease shows certain geographic patterns. Listen to this now. It is a much greater cause of illness and death in the United States and Europe, for instance, than in such places as Japan and countries of the Middle East. And certain racial patterns are also apparent. Within the US, breast cancer has traditionally been more common among whites than among black women, although this difference seems to be fading. Why do you think it is fading? Diet is changing. Who said that? Thank you very much. Diet is changing. The cause of breast cancer remains unknown. Both heredity and environment appear to contribute to its development, but diet had been associated and investigated. And when Sister Herbert comes before you and tell her, leave the meat alone, don't blame her, she loves you, that's why she says that. Hormones which induce changes in breast tissue at menarche, menstruation time, with each menstrual cycle, during pregnancy and lactation, and at menopause, also influence the course of breast cancer. Searching for an explanation for the wide discrepancies in breast cancer incidence in different parts of the world, epidemiologists have found that in areas where breast cancer is common, diets that are high in fats and animal protein, the culprit. Americans, for instance, consume 3 times as much fat and more animal protein than the Japanese. And the incidence of breast cancer is proportionally higher. As countries consume a more Western diet, in which fat constitutes 40% of the calories, breast cancer incidence rises. In Japan, the incidence of breast cancer has increased sharply since 1966. During the same period, dietary fat has risen 250%. Similarly, the incidence of breast cancer is rising in Ireland as the national diet shifts from predominantly fish and sheep to a more Western diet. Why do you think they get the Western diet? McDonald's is cropping up in these places, yes. And an interrelated factor may also be socioeconomic status. As socioeconomic status goes up, so does breast cancer incidence. This could reflect the fact that the affluent tend to have diets rich in fat and animal protein. Within Japan, I'm going to go back to Japan again, the risk of breast cancer has been found to be 8.5 times higher among the wealthier or women who eat meat daily than among the poorer women. What Bible story do you think of now? Daniel. Remember Daniel? He didn't eat the kings from the king's table, and they were healthier than the others. 85% of all breast cancer are small enough to be considered operable at the time they are diagnosed. Nevertheless, about 50% of the women with breast cancer eventually develop metastasis. What is metastasis? It's spread. Early detection, important, can't be stressed too much. A variety of therapeutic procedures can successfully control the disease for a time, but diet and lifestyle cannot be set aside. No available therapy is capable of curing breast cancer once it has become widespread or metastasized. So what do they give you? What? They give you chemo. Because the cause of breast cancers are unknown, it cannot be prevented. But if we eat better and follow the 8 laws of health, where's my chart? Wait, move it for. And follow the 8 laws of health, no matter how many times Sister Herbert has to knock it in your head, she wants you to be healthy. Thank you. Put it back there. Put it down now. Thank you. The best hope lies in early treatment, which in turn is made possible by and diagnosis. So early detection is the key. What do you think? Each person's cancer diagnosis is as different as the person it affects. You know that? So because it happened to one person doesn't mean it's going to happen to you in the same way. What we're trying to do is to offer you some information that will help you to understand that early detection is the key to freedom from breast cancer. Early detection. Glad to hear it. So why do we do breast self-examination? Although regular physical exam by a physician and mammography, when indicated, are very important, the woman herself plays a major role in early detection. Through regular breast examination, and we're going to give you some paper with that later, BSc, she can often pick up and bring to the attention of her doctor breast abnormalities that may be early indicators of cancer. Some husbands have found lumps too. Many women would come and say, my husband said I had a lump there. I don't know what he was doing, but he found it anyway. Should a breast abnormality prove to be cancer, a patient can be treated promptly. That's why you have to do it. At what time did I say I have to examine your breast? Huh? You forget already? No, you shouldn't examine it, and you should do it when your body is wet. Why? Whereas the 5-year survival rate for all women with breast cancer is 68%. The figure jumps to 88% for women whose disease is still localized at the time it is diagnosed. That's how important early detection is. No physician can know your breast better than you. No physician can know your breast better than you. So if you are examining your breast every month, at the same time, it should be the same time every month. Why the same time every month? Because menstruation changes the breast. And look at this, it says breast cancer survival rate. Look at it. This is patient, on this side is patient, you can point it there. These kids are good boy. Go back. You see this, 94% here? And this is from 0.5, 1.5, 2, and the lower level, showing the years after initial diagnosis. So you see, if the earlier one, 94% who are diagnosed early. See it? 94%. You see that good enough? We can keep going? Now we're going to deal with the male breast. For years, we only dealt with female breasts. But now we're going to deal with male breasts. Although it occurs infrequently, breast cancer can affect men as well as women. In many ways, the disease appears similar in the two sexes. However, because male breast cancer is so uncommon, it has been difficult for researchers to accumulate extensive data, and several aspects of the disease have been the subject of disagreement even now. In general, men tend to be somewhat older than women at the time of diagnosis, and the disease is often at a more advanced stage. I don't know if you were watching the news today and you saw this week Beyonce's father. Okay, in general, men tend to be somewhat older than women at the time of diagnosis. He's 68 years old, remember that? And the disease is often at a more advanced stage. Like women, men are commonly treated with surgery for primary disease. For advanced disease, they usually receive some kind of hormone therapy, which is even more effective in men than in women. Isn't that something? Men are less likely than women to develop cancer in the opposite breast, but more likely to have or to have had a second type of cancer in the past. Men were thought to have a poorer prognosis than women, but it now appears that in cases that are otherwise comparable, any difference in prognosis is slight. The critical factor are prompt diagnosis and treatment from early detection. Men, it's not easy for men because usually the lump appears in the pectoral region, which is so close to the chest wall. That's why we're going to show them how to examine it now, later. Look at the male breast cancer symptoms. A painless lump, usually discovered by the patient himself, is by far the most common first symptom of male breast cancer. Typically, the lump appears beneath the areola. Where's the areola? The breast. Remember, we just showed you before. You have to remember what we went by before, eh? Where breast tissue is concentrated. You see, and the man doesn't have the bulk of the breast that women have. So most of the tissue is concentrated in that area. So that's where you would find the problem. A lump is seldom the only symptom. Men are more likely than women to have nipple discharge, sometimes bloody, and the sign of local spread, including nipple retraction, fixation of the skin, or the underlying tissue, and skin ulceration. About half the men with breast cancer have palpable axillary lymph nodes. And later, Sister Liz is going to show you one exercise for the lymphatic system. Most male breast cancers are not large. Why do you think it's not large? They don't have that much tissue to have a large one, the tissue. One study that reviewed a large number of cases found that 51% of the tumors were less than 3 centimeters in diameter. The largest, however, measured 28 by 16 centimeters. And you know, 3 centimeters is very small. Yes. Look about the delayed diagnosis. The fact that breast cancer in men has often spread locally before it is diagnosed, even though the small male breast should facilitate early diagnosis, has been attributed to several factors. One, the very smallness of the male breast could be a factor. Lacking the bulk of the typical female breast, even a small carcinoma in a male lies close to the skin above it and the tissue of the chest wall beneath it. Consequently, the cancer can more readily invade these nearby structures, mostly around the nipple area. Many people are unaware that men can develop breast cancer. You think that? It's only later when we're hearing more about it. And neither individual men themselves nor their physician regularly examine men's breast. So the men have to get to the point now when they go and say, "Doctor, would you examine my breast?" Because they're not going to examine it normally. When men discover signs of breast cancer, they tend to delay before seeing a physician. Why? Review of cases diagnosed over the last few years showed that men waited 18 months on the average before seeking medical advice. For men diagnosed since 2000, this dropped to 10 months, thank God. Such a delay may be in part occur because some men perceive breast cancer as a flaw in their masculinity and are reluctant to acknowledge its presence. Some risk factors in male breast cancer. The incidence of breast cancer in men, like breast cancer in women, increases with increasing age. Ethnicity. Breast cancer affects 14 black men and 8 white in a million. Geography. In Egypt, male breast cancer represents 6% of all breast cancer, and in Zambia, 15%. So where you live has something to do with it. Why? Climate. Should be that too. Socioeconomic status. Breast cancer patients were more likely to be college graduates and employed as professionals or managers. That's for the men. Heredity. You know what heredity is already. So let us give you a case history now. This week, I was watching TV and I saw where Sister White, you want to help us with that story? She laughed. You were the one, remember, when I was talking about it, you were the one said Beyonce's father. Yeah.
You wanted me to talk about the news, what we saw? Enlighten me, Sister God, I don't know which one you want. Yeah, this week we saw in the news where Beyonce was, his father coming on with cancer, and I know that we don't think, men can have cancer, but, he said he's going to be an advocate now for the men to let them know that, they have to take care of their body and, check with the doctor regularly.
Thank you. You remember we spoke just now about men that are likely to get it are executives and managers? Well, Dr. Matthew Knowles is an American music executive, businessman, record producer, and manager, best known for being the manager of Destiny's Child. Anybody know that? He has 2 daughters, Beyonce and Solange J. He was also going to the gym. Goes to the gym very often, exercising, and he saw a little drop of blood on his T-shirt. He just saw a little blood on his T-shirt, and he said, "Oh, because I was exercising so hard today." But when he went home and he was telling his wife about it, when he went back home and he said to his wife, "I've been seeing these spots on my T-shirts." She said, "I've been seeing those spots on the bed sheets, And I was wondering where it came from. So that prompted him to go get himself checked. And would you believe it was 4th stage? 4th stage. And he had to get a mastectomy. But they found out that he has BRCA2 genes. I don't know if you ever heard of BRCA2 genes. But it's his familial. So if it's in the family, and since he got it, he's worried for his girls now, if they are going to get breast cancer. The BRCA gene, in addition to carry the genes that cause breast cancer, also causes melanoma, pancreatic cancer, and prostate cancer. I tell you, it was 4th stage. You know that when cancer is stage, you have 4 stages. 1, just pray that if you examine your breast, you may come up with stage 1. But heaven help if you are stage 4. Because they had to give him mastectomy. Mastectomy. and all kind of, not even the radiation. The radiation can burn your skin, but think of the chemotherapy. Chemotherapy doesn't know what it's doing. So it's ruining good tissue as well as bad tissue. So when you go to the hospital, the doctor says, one of the first questions to come to a patient when the doctor says you have cancer, what they ask? They don't know about stage. How long am I going to live? How long do I have to live? That's the first concern when the doctor says you have cancer. But the stages help us to know that when you're at a certain stage. And since we are here, or when we go to the younger people, go ahead now. Breast cancer awareness entails knowing the anatomy and physiology and understanding the breast changes. That's why we went through those parts of it. You have to know the breast changes. That's why you have to know you cannot do it when you're having your period. You have to do it. And I'm telling you, sometimes the men come and the men say, but they're going to have wives later. Some of them already have wives, have daughters. So all of us need the information. All of us. Thank you very much. I don't know where I am now. You're getting me lost. Young women and breast cancer. And I was so disappointed that the young people left this evening because they figure it won't bother them. Yeah. Breast cancer is more aggressive in younger women for the same reason we said before, but because of the cells and all the cells. Oh. Breast cancer in women aged 40 or younger isn't common. So if it's not common, what do you think happened? They are neglected. They are neglected. About 6 to 7% of all breast cancer in the United States are diagnosed in women in this age group. Young women have worse cancer outcomes. Breast cancer diagnosed in younger women is likely to be more aggressive or metastatic, and diagnosis and women in this age group have worse survival rates. That's why young people should be trained about this. Let me just tell you one about this young woman. This young woman came down with a lump in the breast. Tell me right now. Tell me about her right. So she went to the doctor with the lump in the breast, and because, no, she was 20, not 20. She was just 20 years old. She went to the doctor with a lump. The doctor tell her, oh, he dismissed her. She was talking about it to a friend. That's why it's so important that you know what is happening. She was speaking about it to a friend, and the friend said, a lump is a lump, so go get it checked. And she went to get it checked, and she ended up at the cancer hospital. The girl had cancer at age 20 in the breast. And by the time they felt the lump, you know that it was far gone already. That's why we need to know about it, and we need to tell our children about it. Another woman, 29 years old. Maybe I should, when I go to the women, when I go to the other state, I don't get carried away. Although breast cancer in younger women is rare, more than 250,000 women in the US today were diagnosed with it, all under 40. 250,000. In young women, breast cancer tends to be diagnosed at its later stages and be more aggressive. Why do you think that? They keep saying you're not to have until you're 45. So if you're under 45, if you have a lump, you're not concerned about it because you're not 45. Young women also have a higher mortality rate and higher risk of metastatic recurrence. Return to the breast cancer in areas beyond the breast. So start with breast cancer and they die from liver cancer. It could breast cancer and die from kidney cancer because when you have breast cancer, it breaks off, it goes any part of the body. Any part of the body. Because the average age at which the disease is diagnosed in the United States is 61, There has been little research focused on young women, and such research is needed ranging from the biology of the disease in younger patients to the particular challenges they encounter. How long have I been up here? No, stop now. A young woman breast cancer study started in 2006 is the first multi-institutional effort to track the medical and psychosocial issues faced by a large group of young women with breast cancer in the United States. Thank God something is being done. What do you say about that? This study enrolled 1,300 young women across the country, and they were dealing with the time of diagnosis and treatment and the post-treatment concern. But they may start too late with this, but it's still hopeful. What do you say about that? I want you to look at this picture. You see the lymph nodes under the arm? When it gets to the lymph nodes, the cancer is really progressed. And you see the fatty tissue, the lobes again, the ducts, the areola, the nipple, and the lobules. And you see where the muscle? And the ribs? Uh-oh, I forget I put the point in, Alex. Sorry about that. Next slide. The lymphatic system, I showed nodes because the lymphatic system is a network of vessels and nodes that work together with the spleen, the thymus, and bone marrow, and it constitutes the body's immune defense system. So understanding the lymphatic system is the key to understanding the spread of breast cancer. The immune system contains high concentrations of white blood cells, known as lymphocytes, which coordinates and execute the body's responses to foreign invaders such as bacteria, viruses, and parasites, and to foreign or tissue tumor cell. And you know that is foreign when it gets in the breast, huh? And this I was just showing the progesterone and estrogen. You see the difference? The healthy growth on the other side, the bone, the brain, the breast and mammary gland, the adipose or the fatty tissue development, and the second. If you see the bottom one, you see this? Huh? And see now when they change, you see, look where it's open, it's going to the blue, is the progesterone and the progestogen receptors. And on the other side is the estrogen bound to estrogen receptors. And that's how the breast cancer, you see that cell proliferation called that. See the cells up there? One cell breaks to two to four, and so on. So it's really. The lymphatic fluid is clear. It bathes the body cells and then drains to the lymphatic vessels which run through the body, usually parallel to the major veins. I was trying to find a picture like that, but I didn't find it. But listen to now. Breast tissues are drained by lymphatic vessels lying in the spaces between and around the milk-producing lobes. Remember that. These vessels lead primarily to one of two clusters of lymph nodes. The axillary nodes, where are the axillary nodes? The armpit. And the internal mammary nodes. We showed you the nodes in the picture before, remember that? Which lie alongside the breastbone. And then we have the lymph from the breast can also reach the supraclavicle nodes. Where is that? Huh? This is the clavicle bone. This is above here. You find the doctor sometimes examining this part and this part. If he's doing that, he's doing a good job. And then we have cervical nodes near the side of the neck. Come on now. Sister Liz is going to give us a little help with the lymphatic system. 8 laws of health. She's going to show you some you show them, Sister Herbert. You know the lymphatic X. Huh? Liz, I was asking Liz, but she said she can't do it. Oh. Go ahead. Just everybody stand up and watch this now. Everybody stand.
Stand.
We're going to show you the lymphatic exercise. Excuse me, please. We just want to do one for the lymph. Chop, chop.
Push, push, push. Push, push, push. Push, push, push. Chop, chop, chop. Chop, chop, chop. Chop, chop, chop.
Push to the side now. Push to the side.
Push, push, push. Push, push, push. Chop, chop, chop. Chop, chop, chop. Push, push, push. Push, push, push. Push, push, push. Push, push, push. Push, push.
Thank you very much.
Thank you.
So what that does is drain the lymphatic system, eh? What that does is what? Okay. You know what? This breast shouldn't be there, but that look like. You see, this is cell growth and division. Remember we spoke of cell growth before? The process of cell division, a single parent cell doubles its mass and become two daughter cells. And the two daughters, one daughter becomes a woman, the other one becomes a mother, and they keep splitting. This is inspection of the breast. See this, look at this breast now. Breasts are inspected in good light. You can't be doing it if you don't have good light. You have to have good light. What are those lines up at the neck? Lymph nodes and but you notice this woman, when she's sitting upright, where are her arms? Relaxed at her side, yeah. Inspection of the breast continue. Look at where, you see how she's sitting? And look on the axillary tail. What you find there again? You find lymphatic system there. You want to find, you see it? Raising arms exposing extreme lateral portions of the breast. Axillary tail and underneath portion. Inspection of the breast continues. Put your hand on your keyboard and you do it. You're standing before a mirror now. Remember that. I mentioned before the time in breast examination. That? You see, they are the best time for breast examination. Everybody see that? By either the physician or the woman is 5 days after cessation of menses, when the morphologic influence are minimal. The fluid that would come in the breast during menstruation is gone by then, 5 to 7 days. Look at the palpation of the breast. What part of the arm is being used? What part of the fingers? So you can't use the tip of your fingers. If you're using the tip of your fingers, the flat, you're doing it wrong. It has to be, and it's better done when you're wet. That's why most times they'll give you a thing to do it when you're wet. The flat part of the fingers are used to gently compress breast tissue against chest wall to reveal breast masses. A little later, we're going to have you come and do some palpation so you understand what it's like. Men and women alike, we're going to palpate the breasts. Not real breasts now, don't get too ambitious, young men. And look at the nipple examination. It's very important to examine the nipple. You see the skin dimpling of the nipple on the right? And you see the underlying tumor? Because it dimpled because they were, it dimpling is saying there's a tumor below. And your molding of the breast about a mass may elicit skin dimpling. Look at this one now, palpation of the breasts. Where you see the doctor, you see the physician hand under the armpit? That's the physician's arm. And it is passively raised and then fully supported by examiner's hand to prevent pectoralis contraction while examining hand is placed high in the axilla. Look at it, look at the picture at the right bottom. You see where his finger is on? What you find again? Part of the lymphatic system. You see it's coming, look from the clavicle. No, you can't see my point. From the clavicle here. This gentleman is helping me to use this thing.
The bone.
That's the clavicle. You see the clavicle bone? Okay. And you see this big one, why you have to examine the supraclavicle ones, because you see it there? Huh?
Blue.
Okay. And then breast examination on your back. You see where the pillow is? What does the pillow do? It tilts the body so that the breast fall to side. You see that? You can't read that? Yeah, you can read that. And then self-breast, look at, I'm going to give you some pictures. You can remember the topic is what? Self-breast examination. So these are very important for you to make a note of. You see what she's palpating with? What? The flat of the fingers, not the tip. So what kind of lump for screening and physical examination? That includes your medical history. Mammogram or zero radiogram. Maybe you never heard of zero radiogram because they hardly do them anymore. Breast self-examination, ultrasound, thermography or contact thermography, diaphragmography, computerized axial tomography. I don't think CT is used much because they only started as an experimental thing one time and it wasn't working out. NMR, nuclear magnetic resonance imaging, and biological markers. What are biological markers? I'll tell you later. An MRI, or the magnetic resonance imaging. This is what the modern equipment look like. You see it? The older ones look like this. You see the tube, the X-ray tube? And look at the breast. You see any difference in these breast X-rays?
Yes.
The one on the left looks normal, no? You see it looks normal? The one on the left is, you can put the arrow over there. The one on the left is normal, see? Look at the middle one now. You see that white stuff there?
Yes.
And look at the one on the right. It has calcification in the middle of the breast there. You see that? Yes. Okay. And these are the more modern equipment. Isn't that something? These are the 3D, Genius 3D they're called. And why do we press the breast? Huh? Why do we press the breast? Look at the shape of the breast. If we just put the breast here and take the picture, what would we get? So if you want to get a homogeneous film, you have to press it. This way you can see equally through the breast tissues. See the position there of the breast? This is the X-ray tube. And boy, women scream when they put it down, but it's so brief. It is so brief. By the time you feel it, it's time to lift up because and it's done. Huh? But it behoves you to be patient when it's being done. Because if you scream and a technician doesn't care, she'll let you get up and go. I'm telling you. And look at this mammogram here. Isn't that a pretty picture? It includes the tail. See the tail of the breast? And that is where if you see it?
Yes.
And that's why they pull you over so tightly to get all that area. So be patient, huh? What about ultrasound? Anybody ever had ultrasound of the breast? It's a painless, non-invasive method for detecting breast abnormalities by projecting high-frequency sound waves into the breast. The pattern of echoes from these sound waves is converted by computer, not a visual image on the interior of the breast. But the computer is telling, you don't see the picture, but the computer tells you what is happening. And you have thermography. What is thermography? When you see thermography, what do you think of? Heat. You think of heat. Some of the heat body emits is in form of infrared radiation. With the aid of spectral radiation, this radiation can be pictured on a film. Diaphanography, or trans-illumination. I have not seen it done for years because, I'm an old girl, so I know most of the earlier stages of stuff. It was introduced in the 1920s, long before I was born. It involves shining a light through the breast to illuminate the interior. Different types of tissue transmit and scatter the light in different ways, and these differences can be more clearly perceived with sensitive television camera and display. I don't think they still do that, but they did it when I was young. CT scanning technology that is being used experimentally, but they still haven't come up with the right thing with the CT yet. For the breast disease, the CT scanner uses X-rays. That's the only disadvantage. It uses X-rays, but from very perspective, the scanner rotates around the patient and takes many views. This information is then analyzed by computer and reconstructed as a series of cross-section display on the video screen. And if the body is in the way you're doing the breast, it's not going to be right, because they haven't found a way to just take the breast and do the slices of the breast alone. That's why it was experiment. And we have NMR, the nuclear magnetic resonance image. It's a highly experimental technique that's using interaction between magnetism and radio waves to portray the structure of biological tissue. And the biological markers, see it come up here now? A substance present in abnormal amount in the serum or urine of a person with cancer. That's why they do a urinalysis and they do a blood test. It can be produced either by the tumor itself or by the patient in response to tumor tissue. MRI now is used to image implants and evaluate for rupture and the extent of disease in women diagnosed with breast cancer, especially those with dense breast called what? Called what? Fibrocystic breast. My goodness, my students are not helping me at all. So general overview of the MRIs as Sister Peters comes to us. In order to understand MRI imaging, you need a background in physics. And nobody wants me to give them a physics study now, do you? The single steps of all MRI examination can be described quite simply. 1, the patient is placed in the magnet. Where is Glennis Peters? 2, a radio wave is sent in. 3, the radio wave is turned off. That's why it relaxes. It comes on, then it relaxes. They call it relaxation. And would you believe that is what makes all that noise in that machine? The patient emits a signal which is received and used for reconstruction to a picture. Breasts are fat suppressed techniques is applied. Because if you have fatty breasts, they have a fat, the suppresses the fat so they can see a better picture. Come on, Glennis. Where's Glennis? Come with your roses. If you were here on communion, here on communion, look at those two pictures. You see they look different from regular mammograms? Give her the microphone, please. Make it as short as possible, please.
Good evening, church. I know most of you heard the testimony, but Sister Gloria said she wanted me to share it again for those who didn't hear. I must just say from 18 years old, they've been telling me that I have all these lumps, cysts, whatever you want to call it, in my breast. The first time it came out, I remember during biology class, they taught us how to self-examine our breast. And from that time, I started doing it. And I was 18 years old when I found the first one right under here. And the doctor said, you know, he don't think it's anything, but he took it out. And after 6 months, he came back doing the breast self-exam again, and I felt this lump, and he took it out. And he told me I must always check my breast. But over the years, I guess as I grow older, I have a whole lot in my breast, and most of them, they said it's, you know, it's okay, it's benign. But there is one, they call it at a quarter past from my nipple, go right here. They say it's a 3:15, come right across here, it's right here. And they're very concerned about this one. And for the past, since 2014, they've been saying I have to do a biopsy, but I keep refusing because I told them I know my breast, you know, more than the doctors. And the sonogram keeps saying, you know, recommendation biopsy, and I refuse. So my doctor got very upset with me, and he said that, you know, that I need to do it. And I said, no. I said, give me an MRI. And they said, no, we're not giving you an MRI. So I said, well, that's okay. So I called my insurance company. And I asked them, I said, can you send me for an MRI? And she said, why? I said, well, they did mammogram. They said my mammogram, and by the way, my mammogram is always fine, but it's on the sonogram. They picked, you know, that thing up. And I told her what happened. They said I have dense breasts and I have something there that they need, you know, me to do a biopsy on, but I keep refusing from 2014. And I don't want to do it, and now they're getting upset with me, can I do an MRI? And she said, okay, let me check your records. And one of the criteria for MRI, you have to have dense breasts. So she came back and she said to me, oh, yes. I said, so can I go where custom go? And I gave her the number, and she called them, and she set up the appointment. Thank God that I was very proactive with my health. You know, don't listen to the doctors. Call your insurance company. Well, some insurance, they don't want to send you, but, you know, if you have the, like they say, the factors that could cause you to get an MRI, then, yeah. So they did the MRI. When you go for the MRI, they put your line down on, like this way, and put your two breasts in two holes, and all this knocking, ding, 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 whatever, you know, for those of you who, yeah, and the results came back, and they said my two roses, they are just perfectly benign. So I just want you to, you know, take care of your health, do your self-breast examination, and know your body, know yourself, know, you know, because we women, we know how we feel, we know ourselves. So this is my testimony to you that my breasts are bilaterally benign, even though they have all these things in there. I wouldn't even let them touch it anyway.
Thank you.
So what we have proven there is that no one knows your breasts like you do. No one knows your breasts like you do. If the breast is not image by mammogram, MRI is also for screening purpose in high-risk patients and patients with implants. You know, the implants are dense. And one of the reasons why they don't do it too regularly is that MRI is more expensive than a regular mammogram. So they'll do it at all costs not to do it. And the case history, and not all lumps are cancer, even though they have the lumps there. But sometimes, no. I tell you not to forward them, I'll do it myself. Thank you very much. Let me go back. Okay. I don't know where it got there, but something must get mixed up. Anyway, look at this solitary intraductal papilloma. You see it?
Yes.
You can see it on the right side. And you see it squeezing the breast. You see that? Palpation will often reveal a mass near the nipple at the duct opening. And when we go there to do the palpation, we're going to show you that too. A certain proportion of premenopausal who develop breast cancer, about 7%, happen to be pregnant women at the time of diagnosis. You think it's going to be hard on a pregnant woman to be told that she has breast cancer? Over the years, pregnant women have generally had a poorer prognosis than non-pregnant women. It now seems clear that the outlook for a pregnant woman is just as favorable as that of a non-pregnant woman of the same age with a similar stage of the disease, provided that the disease is diagnosed and treated promptly. That's why we need early detection. If it's found and you're treated promptly, you can survive. Unfortunately, history shows that delays have been common in both the diagnosis and treatment of breast cancer in pregnant women. Of breast cancer during pregnancy is complicated by the fact that the breasts normally are enlarged and grow more glandular at this time. Any lump that develops may be hidden by surrounding tissue. You understand that? If lump can be felt, they may be dismissed as normal. A woman, 29 years old, who is used to breastfeeding, Daphne and Sister Burnett, they do breastfeed, they encourage the women to do breastfeeding. So this woman shows up, she says, this 6-month baby is not taking the breast anymore. And then it's hurting. And it doesn't feel as if when the breast is engorged, a different pain. Different pain. What do you think she did? She squeezes the breast, and she realizes not milk coming out, it's pus. So she went to the doctor. And what happened, Daphne? Tell them what happened. Because she was only 29 years old. Yeah. Have mercy. And she has 3 more children, 2 more children, plus the baby, 6-month-old baby. And it's stage 4. That's why when we get a subtle warning, we have to follow up on these subtle warnings. We cannot let it go by. If lump can be felt, they may be dismissed as normal changes when you're pregnant or when you just have a baby. But the doctor should really investigate. The breast tissue changes produced by pregnancy also obscure tumors on a mammogram. So even if they had a mammogram, sometimes it's not going to show what they should show if you are pregnant, because the breast changes already. As a result of these problems, 3/4 of women who are pregnant have been found to have positive lymph nodes at the time of treatment. And what do we say about the lymph nodes? If it gets to the lymph nodes, you know it's far gone. Far gone. When a suspicious lump is found, prompt biopsy is just as appropriate for pregnant women as for non-pregnant women. Watching a lump is never justified. As you find a lump, you should take care of it. Biopsy can be performed with minimal risk to the fetus. Even while you're carrying the baby, they can do biopsy, and with no risk to the fetus. Watching a lump is never justified. Because it's going to be too late if you allow it to get worse. And once your fourth stage, what did I say? It's bad. They can't give you anything to heal you. And look at this now, the mammary duct estasia. You see, it was a mild, look at the first picture. Where am I think? It's just a mild nipple. Where am I going? Watching a lump is never justified. I have to start there so I know where I am. Thank you. So this is the mammary duct. You see, it's holding the mild nipple retraction. If the nipple is retracted, go to the doctor. And you see, when she squeezes it, what comes out? Thick, green, discharge, suggests a mammary duct estasia. Associated subareolar mass and our nipple retraction may also be present. Treatment requires major mammary duct excision, including the surrounding inflammatory tissue. So if you're going to lose more of your breast. We did these already. Rejected them, those case histories already. And look at this breast. What you see you see the vascular signs? You see the blood vessels showing so brightly? See? That could be a sign of breast cancer. The superficial veins are dilated. And see when they cut, you see where they operated? See the carcinoma here? The white tissue part there is the carcinoma. And you can see the blood vessel on top here, the breast that they did. I told you I worked with, so that's why I have a little information. So just pray that somebody gains something from that. Look at the clinical signs of cancer. You see the breast on the left? Skin dimpling. You see the dimpling? What do you think? Skin dimpling right here. Look at the regular x-ray down here. You see this here? Huh? That is the carcinoma right there. And see when they open up and cut the slice out, see the dimpling right here? And this is what was under the dimpling. See that? Look at this now. Nipple retraction. That's one of the signs you have to look for when you examine the breast, if the nipple is retracted. Look at the mammogram again. See the mammogram? Look here. See the carcinoma right here? Eh? Boy, the people not talking to me at all. And see the retracted breast, nipple? And if you look here, you can see the vascular shadow here. You see the vascular? Mm-hmm. And see when the carcinoma is involving the mammary ducts. And maybe that's why, and I don't know if the lady's breast was retracted. Was there any retraction of the breast, Daphne? But this is a needle biopsy. And they use disposable needles. If you see this one here, disposable biopsy needle. This is the cannula right here. So the closed needle assembly is advanced to edge to the lesion. You see that? And then they put here. Then this is the obturator, this part. And this part here is the lesion. So they put the needle in, and then number 2, the tip of the obturator is advanced into the lesion. Tissue prolapses into open specimen notch. See that? This is the open specimen notch where the arrow is. And then the cannula is advanced over the obturator, entrapping tissue specimen with notch, and then the needle is withdrawn. So sometimes they say they're going to do a needle biopsy, and you're so scared of the needle biopsy, but it's not bad. It's better than cutting the breast to find out what is happening. Sometimes after they do the needle biopsy, they have to cut the breast off too. But at least they didn't cut it off first. And look at this, and sometimes if you have cysts, they can just go into aspirate it. See the cyst there? And look at the finger that he's using to decompress the cyst. You see that? The tip of the finger, like this. And this I showed you before. My references as I prepare this thing, from the Breast Cancer Digest, my course book when I studied the breast with the U.S. Department of Health and Human Resources, research from ACS, American Cancer Society website, and other sources from the internet, knowledge from previous studies. And I tell you before, I'm not a clinician, but work in the field with clinicians and observed a lot. And then I studied from the book Clinical Imposure by Dr. M. Townsend with SIBA. Early detection saves lives. We hope you got something from the presentation that will help you to realize that early detection saves lives. Use the information to help others by encouraging them to take care of their health. Remember to share this information with your friends and neighbors. You can help to save lives. We thank you very much for taking a Sabbath evening to spend with us. That's the end of it. At this time, Elder James is going to come to us.
For attending. Thank you very much. Please come back next time. Please come back next time. Don't leave yet.
Where is
Explain it to them. Will you explain what the thing was for? Okay. We have, did you all learn something this evening, something new? Okay. So we expect for you to go out from here and to inform your relatives and your friends, and for you to take active part in your own body. Know your body. It's one body you have. You can't borrow anything else. So you learn your body, know what it's all about, and do your monthly self-examinations. Okay, we have some prayer requests here. We have been talking about the prayer of pink and prayer, the power of pink and prayer. I have some flyers to give out. The power of pink and prayer. And we ask you all to put on the paper, if you know anyone that have breast cancer, that we're going to pray for them at this time. Did you all put the person's name, everybody's name on this, on the, okay. We are going to pick up an offering right after the, what? We are going to take a donation right after the presentation. And we're asking you all not to just give me $1 or 50 cents. We have to send it into the American Cancer Society and we need to send something because they're doing research. You see what's going on now with all these cancers, and we're doing research, continuous research. So it needs money. We need money. We need funds. So please, when the gentlemen come around to pick up the donation, please give us something that we could send out to from Christian Fellowship Church. We don't want when they go to Christian Fellowship Church, it's few cents from the church, okay? Okay, thank you very much. Elder James, will you please come now, and we're going to pray for people that has cancer and for families who have lost loved ones with cancer. When are you going to do it? You had called it, when are you going to do the palpation? Or after the prayer, we're going to come. Are you going to do the breast return? Okay, okay, before Elder James comes to us, we're going to do the palpation of the breast. The breast forms are up here. And come up, men and women, please come up. You have to touch it. You must touch it to feel it. Men and women, please come up and feel these forms. Alexander, I need for you to come over here and do this form. Come on, you're a man. Come over here. So you could know what's going on with your breast. Come over here. Brother Brian, come over here too. And I'm not going to let you off the hook. Not the woman alone. Yeah, give it on. Every form a line. Folks, do not leave, please. We have gone through all this evening, this very technical presentation here for you all to learn something. So please do not leave, and please don't leave with a donation. Thank you very much.
Or without your T-shirts.
Or without your we have T-shirts here. We have T-shirts, we have small, not small, medium, large, and extra large. Only without your T-shirt. It's for everybody. everybody to get a chance to have it done. Young man, hello.